Okay, so I'm going to talk to you about a topic that I dare say you have not heard about in medical school. But it's one, whether you go into pediatric or adult medicine, is going to affect the outcomes of treatments that you prescribe for your patients. And a big factor in your success is whether your patients are listening to you and following your advice, and that's called medical adherence. And there's been a fair amount of research done on this topic, and we've sort of been one of the leaders in the country in pediatrics on this topic. I warn my graduate students that you have to be very careful what you do your dissertation on, because it follows you throughout your career. So 1980, when I graduated from KU, this topic has continued to dog me over the years. Hopefully we've learned a little bit since 1980, and I'll try to share some of that information with you and give you also some very practical kind of advice about what you can do as a doctor. I would recommend this book to you. How many people know this book? It was on the New York Times bestseller list. Did you like it?
I haven't finished it.
Haven't finished it. It's a very interesting book by Dr. Groupman about the sort of errors that physicians make. Now, psychologists call these cognitive biases or cognitive errors or heuristics, and they're very well known, but he's done a nice job of putting that in a medical context and talking about how even experienced doctors can make some mistakes because of certain kinds of biases that humans have. Our big brains sort of have some predictable errors that we make in our thinking, even if we're very experienced. But Dr. Groupman made this comment: physicians like to succeed in their treatment, and an essential ingredient for that success is a patient's cooperation. So that's the issue of adherence. In pediatrics, when you prescribe medications for children, for example, they end up in various places. It can be under the couch, it can go down the sink, and sometimes you think they took them, but they really didn't even swallow the pills. This cute little girl, who's going to be 29 in August, is Lindsay Rapoff, my daughter. She continues to give permission for me to use these photographs, and she's a marketing executive here in the Kansas City area. And I have two great kids. We have a 25-year-old fireman son, who's a fireman out in Rawlins, Wyoming. My only regret, they're great kids, and we've enjoyed them immensely, but they were K-State grads. We have K-State grads in here? No, usually K-State grads. So yeah. So anyway, this big KU grad professor got these two kids that went to K-State. But they had a good experience, so we're okay with that. So this is what I'd like to go over with you today. We're going to talk first about measures of adherence, because once we get into talking about how much of a problem it is, you sort of have to know, well, how do you measure it first? And then we'll talk about the types and prevalence and the consequences of non-adherence to medical regimens. We will then go into factors that have been associated with or correlated with non-adherence, and then finally some practical strategies for improving adherence. So adherence definitions, these two are side by side, as you can see. This is the one that's been used in the literature for many years, since 1979. This is a more recent one from the World Health Organization, and they're very similar except for one key point. They both talk about behaviors, that we're focusing on behaviors that are related to carrying out a medical regimen. And that could be taking pills or following a diet or executing some lifestyle changes. And whether that really agrees with, corresponds with medical or health advice. How closely does that match what the doctor prescribed? The different one here with the World Health Organization is they've said corresponds with agreed recommendations. What they're putting in there is that you should secure agreement with your patient from the beginning that they're at least willing to try to follow your regimen. Many of us have had the experience of going to see the doctor. The doctor's giving you a prescription. You walk out with no intention of filling that prescription. Have you had that experience, or of not following your doctor's advice? Yeah. I had a compression fracture once from playing softball because I was playing with much younger men, and I had a fishing trip the next day, and I went to see my doctor, and it was before I saw Mark Meyer. It was before Dr. Meyer started here. I've been here so long. You all know Dr. Meyer, right? Yeah. And Larry Perry was my doctor, and Larry says, "Oh, I think you have a compression fracture. We'll take an X-ray and see." And indeed, I had one, and he he says, you know, you got to rest for a couple weeks and blah, 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 pain medicines, all that stuff. My wife was with me, and she always snitches on me if she's with me, and she said, you know, Dr. Perry, Mike thinks he's going on a fishing trip tomorrow with the boys in Minnesota for a week, riding around in a boat, you know, blah, blah, blah. He said, oh, Mike, you can't do that. No way you can do that. So we walk out of there, and I said, okay. Walk out of there, my wife says, you're going to Minnesota, aren't you, on that fishing trip? And I said, absolutely. She said, you know, I can hang out with the boys, and maybe the beer can substitute for the pain medicine, is what I was thinking. So, but Dr. Perry was right. It was kind of a rough trip in Minnesota. But I had no intention of following his advice. I didn't let him know that, but certainly my wife knew me well enough to know I wasn't going to do it. So that's the difference here, is this agreed upon recommendations, and the recommendation that physicians really determine whether patients are willing to follow their advice from the beginning. There are a few medical caveats about adherence. Providers need to be adherent themselves to recommended clinical care guidelines and prescribe efficacious treatments. Doesn't always happen. There's very good evidence that minority children with severe, moderate to severe asthma are not prescribed inhaled corticosteroids in the numbers that white children are. They also have a much higher death rate from asthma. So there are physicians out there who are not adhering to recommended clinical care guidelines. And you can't expect people to be efficacious to to be adherent to treatments that are not efficacious. Avoid the blame and shame approaches, shaking your finger at your naughty patient for not minding you and not following your advice. It doesn't work. Encourage an active role for patients and families. I think they do that already, you know. And then there are instances where people are non-adherent, and that's rational and adaptive. Turns out that was a good decision. They've had a side effect that's fairly serious. They stop a drug, and it may have even saved their lives in some instances. So there are instances where people make very rational decisions about being non-adherent, and it turns out it was a good decision. So how do you measure adherence? These are listed basically from the most to the least objective. Drug assays, observing, automated devices that I'll talk to you about that measure maneuvers consistent with adherence, pill counts, treatment outcome, provider estimates, and patient reports. They each have their own advantages and disadvantages. Assays, as you know, when you get a drug level, you use that to adjust drugs. They're objective and quantifiable. The pharmacokinetics are a bit tricky, particularly in pediatrics. Absorption and excretion are affected by a lot of factors, not like pH levels in the stomach, that sort of thing. They're also short-term, and if you're getting a blood draw for children, it's invasive. Now, if you, for example, drew a blood level on, say, phenytoin or some drug for seizures on a Monday, how far back would you know about adherence? And I know that depends on the half-life, but just think of it in general terms that maybe most drugs have, you know, 3 day half-life. About how far back would you know that they were adherent? I probably just gave it away telling you the 3. It's about 2 or 3 days, actually. So think about that. So your patient comes in 2 or 3 days. If they wanted to appear to be adherent, what would they be doing? Taking their medicine, right, regularly before they come in. The other possibility is that they've been taking it regularly and they've missed a couple of doses and they look non-adherent when in fact over time they've been pretty good about taking their medicine. So it's a very short-term measure, but it is the only way, until a recent development I'll tell you about, of really knowing whether people took their medication. Observation measures are good if you can directly observe people. Sometimes family members can do that, particularly with non-medication regimens like exercise and diet and things like that. And you can measure on repeated occasions. They're obtrusive and reactive when you're observing people, their behavior changes, and it's difficult to obtain representative samples. There is something called directly observed therapy. Has anybody heard about that? They're doing that in some inner cities with people with TB, where they're afraid of communicable diseases, and they have the people actually come in and get their medication from a nurse, and somebody directly observes them taking it. That's one of the ways that they do observations. The exciting development in adherence research are automated measures that give you precise, with medications, dosing and dosing interval data, and it's a continuous and long-term measure. Most of the devices don't measure consumption, although that has changed recently. And there have been mechanical failures with some of these devices. Let me show you a couple examples. This is the MEMS. This is an older one, but it's the medication event monitoring system. The patients can't really see this microcircuitry, but there is microcircuitry in there. When they open the container, it records the exact time and day that they opened it. And you get a printout like this. So you download the data, and it shows you the exact day, the date, and the time when they opened it. You can also enter in information about when the patient opened it to fill their prescriptions so that you're not thinking that's an adherence event. This is another device that you can fit on a meter dose inhaler. This one records the date and time. Most of these devices record anywhere from 13 to 1,500 events. Okay? And wireless transmission where you can download the data. It has an onboard display, and most of them have an onboard display and alarm. So you can set it up as an intervention where the patient has an alarm on that. It beeps when they're supposed to take their medication. And this one in particular, I'll show you the data. Went a little too far. The data you get from this is that it shows the exact time. It does show if they shook the medication. Now that's important for inhaled drugs because you need to shake it up to have the full intensity of the dose. It does record whether they inhale or not. The company claims that they can tell if there's been a gas exchange in the chamber that's consistent with inhaling. My biomedical engineering PhD brother, youngest brother, tells me that's possible, so I'm going to believe what he says, not the company. So this one actually can record consumption. Most of them don't. And you can get some interesting printouts that you can show to patients. This shows the percent of doses taken over days. This is from an actual patient in the study that we did who had asthma. And we would download the data and go over the data with the patients. And we would say in a very non-judgmental way, what happened on this day where he got this 0? Turns out that this little boy was staying with his aunt that day, and he didn't bring his medications with him. So the solution to that was to have an extra set of meds at his aunt's house, because he stayed there regularly. He had a single mom, and the aunt was very helpful in helping to take care of this young boy. So you can really use this to kind of intervene. There are now capabilities of downloading the data from these devices from the patient's home. So they can download the data go to a secure website, the healthcare provider can look at that data immediately or review it at some particular intervals, or the nurse could in the clinic, and then you could look at whether you need to intervene or not. If a patient's having trouble, they're forgetting medication, you give them a call and say, you know, Mrs. Johnson, or it looks like Johnny's missed medicine on a couple of days this past week. Do you know what happened? And people are doing that now as an intervention, particularly with elderly patients who have multiple medications that they're trying to track, and they often have trouble keeping track of those. Now, there has been a recent development. I've been talking about this in the abstract for years and years and years, but I recently heard that there is a pill now that has a device in it, very small little edible microchip that's in the pill that will tell you when the pill was digested. So you get data, and it's on a little strip on the patient's back, and somehow it communicates this information. I don't know how it does it. But anyway, this edible teeny little microchip is in the pill, and the doctor will know the exact moment when you digested the pill. That's the most recent development in. So we finally have a device that actually shows whether ingestion occurred. And well, this company that's investing in it, it's interesting. They're doing the initial trials in Britain. They're not doing it in this country. So it's probably a few years off, but it's probably going to be the next, at least, research tool for looking at whether people take their medications or not. Now, in all these studies, of course, you might see this as Big Brother kind of watching over you, but you have to consent to these kind of things. So I didn't think, I thought it would come about at some point because, we have the camera now that's in pill form. Have you seen this? You guys have heard about that camera. They use it for diagnostic purposes. It goes all the way down through your system, and the doctors can see all over the place and see if there's anything going on with you. So now we have that for measuring adherence.
Typically, meet a lot of opposition from kids when you say, I'm going to be loading your pills with microchips and all this stuff, and we're going to be watching your every move. You get kids like, who just want to just oppose you?
Yeah,
It seems like that's what I would have done.
yeah.
If someone said, I'm going to load you in a halo with a tracking device.
Because you were an oppositional child.
Oh, yes.
Yeah. I need to repeat your question. So the question is, would kids, and maybe even adults too, object to something like, a device like we were talking about that had a microchip in it, or even the electronic measures that we have now? We have not found that to be the case. People have consented to the studies, and if they've not, that's not been the reason they've cited. The most common reason for people not participating in studies is they're too busy. But I've never heard anybody say, I don't want any monitor. Now, I did have one child where they brought back the MEMS monitor, and it was completely destroyed. Now, the child claimed it fell off the counter in the kitchen. And that would have had to have been the space shuttle counter with how disintegrated this thing was. This kid clearly took a hammer to it. And he was a little ADHD, and he had some interest in how things work. And I think he just pounded it, wanted to look at the insides. So we've had a couple of those kind of things. We've had kids a couple of times try to fake out. What they would do is like open the container a bunch of times. Well, we knew that they were doing multiple openings within a very short period of time. I mean, we knew they didn't have 17 doses in 30 seconds. So most of the time you can kind of tell that those things have been done. So there are attempts to kind of circumvent the system, but I wouldn't say that most people adapt to it too. It's interesting. If you look at what we normally do is baseline them for the first 2 weeks. We throw the data out because we think it's reactive. So their adherence probably goes up those 2 weeks for a while, and then it starts to kind of level off, and then we start our baseline. So it does have a little bit of a reactive effect. But it's amazing that it kind of goes away pretty quickly, which is really consistent with observational studies where they would put tape recorders or video machines in people's homes and record them at mealtime, or couples talking, or most people adapt to the equipment and all that within a short period of time. Good question. Pill counts, amazingly enough, they do these in a lot of drug studies. So you count how many pills you got when you give it to the patient, and at the end of the study period, how many are left. And then you figure out what % are missing. Well, all you know is they're missing, right? You don't know. The dog ate it, or somebody in the family ate the pill, or whatever. Treatment outcome is not a measure of adherence. If you look at a person with hypertension, and they come into your office, and they're not well controlled, and you've prescribed a dose that you know is efficacious, what are you going to conclude? Your blood pressure is not under control. You've prescribed the proper regimen. What's your first thought? I'm not taking it, right? Which is not a bad thing to think about. I mean, my whole point of my lecture is I want you to think about that, but that's not always the case. Lots of things can affect blood pressure. White coat hypertension, for example, you go in there. I get that all the time. I hate going to the doctor. I go into the doctor, my blood pressure is always up the first time they take it. They take it later on in the visit when I've calmed down, and Dr. Meyer is very calming. Then my blood pressure is always lower, right? So you've got to be very careful about treatment outcome as a proxy measure for adherence. There's not a one-to-one relationship between adherence and outcome. For example, most of the time we don't know how much medicine do people have to take to get a good outcome. For example, with antihypertensives, what would be your guess? 70%, 80%, 90%? What percent? Overall, kind of on the average. What do they have to take to get a systematic decrease in blood pressure? 80. It is 80. And so now that's become the convention in the literature because the early studies were all on antihypertensives. Turns out that's not a very good standard for heart regimens for HIV, for example. You have to be 90%, maybe even 95% or more adherent to really get viral suppression. So that data needs to come in. We need to be doing studies not only on adherence, but looking at outcome and matching what degree of adherence is necessary. What's the minimal degree necessary to get a good therapeutic outcome? And we're starting to get some of that data, but we haven't had that, amazingly, for a long time. Physician estimates are not very good. They're not even good if you're experienced. So the doctors that are training you here, they're very good doctors, but they're not very good about estimating adherence. They commit a certain kind of error that psychologists call the optimism bias. What they believe is that other people's patients are non-adherent, but not theirs. So if you ask them to estimate, how likely is this patient of yours going to be adherent? And you do that for a bunch of patients, they're going to estimate that most of them are going to follow the regimen, and they're going to miss lots of people who are non-adherent. And we did that in a study here with otitis media, asking physicians to rate whether they thought their patient would be adherent or not. And they erred in the direction of saying most of their patients were adherent. Okay? Kind of like smokers that think they're going to get away with it. You know, they know that smoking causes cancer and a bunch of stuff. But they're going to be that one person that lives to 97 smoking 4 packs of cigarettes a day, right? And they pick out that one example. So that's the optimism bias. Patient report has gotten a bad rap because we've asked people in really silly ways about adherence. We've asked in very judgmental ways like, Mrs. Johnson, have you given Billy all that medication I prescribed? That's an are you stupid question. Or is your baby ugly if you have a new mom? It's a dumb question. It's not a very helpful question. And there are ways that you can improve question asking about adherence that will give you better information. And that's to directly evaluate adherence behaviors in an information-intensive approach. What medicines are you taking? What dose? How often? Have you had any side effects? Probe for non-adherence in a non-judgmental way. Many people have trouble remembering to take their medication, and I'll show you how many in a minute. It's almost the norm. Half people don't take their medications. Do you ever forget to take yours? Do you ever stop taking your medication on purpose? There have been times when our children were littler and our son had asthma, we had to give him lots of treatments and stuff, where I would say to parents, it's tough to keep track of that. Even my wife and I, who's a respiratory therapist, sometimes say, did you give Nathan his medication today? Or, you get kind of mixed up on that. So it's real easy to forget. And if you give that kind of information to people, they're much more likely to give you accurate information. The other thing is the time frame for questioning should be limited to 7 to 10 days. Why? Because human beings don't remember most things beyond those 7 to 10 days. You know that from studying for your pathology exam or your anatomy exam or something like that. You forget it within a short period of time, unless it's a really salient event. So I'm going to ask you just a hypothetical question. I certainly don't want an answer to this question. But if I said to you, and this is what they do in studies, they ask people about adherence, in the last 6 months, how many bowel movements have you had? That's what they say to people about adherence. Okay, so the last 3 months, how many bowel movements have you had? Yeah. Okay. Not good. Last 2 weeks. Might be able to get that one pretty well. But if I ask you in the last week, okay, it's Thursday, you can say, I think I pooped this morning. I pooped yesterday. I didn't poop the day before. I remember because I was somewhere in So you could kind of go back 7 days, and you probably get a pretty good estimate of how often you pooped. But that's not what we do. We ask people over the last 3 months, over the last 6 months, how many doses did you miss? I mean, it's really kind of a silly question. And then, because these don't correlate with more objective measures, we call them unreliable or non-valid methods of assessing adherence, when really we're taxing the memory of people. And then ask families about barriers to adherence. So how much of a problem is this? These are the types of medication non-adherence problems: not filling prescriptions, delays in refilling, particularly with older people, and particularly with this economy. People are not refilling their prescriptions. Omitting doses, taking a drug holiday, no doses for several concurrent days. With some heart medications, if people do that and then they go back on the full dose, you can get into real trouble doing that. Then there's the toothbrush effect or white coat adherence, increased adherence around the visits with the doctor. Toothbrush effect, you've all have experienced that. What do you do like the day or so before you go to the dentist?
Brush your teeth for like a half hour.
Yeah, and you floss. Because the dentist is going to ask you about the flossing. So that's what I do. I floss a lot. I do it anyway, actually. I'm pretty compliant about that. But most of us do that, and that's the toothbrush effect. So there have been studies looking at electronic monitoring of adherence, and it shows that people's adherence during the peri-visit interval, before and after the visit to the doctor, their adherence increases, okay? And then people overdose or take extra makeup doses. Of all these, which one is the most common, do you think? Most common here. Omitting doses, right, is the most common. Now, these rates hold up very consistently for adults and children. About 1/3 of patients on short-term regimens finish their treatment. When do they stop? When they feel better. And when do they start to feel better? Say it's the old 10-day regimens. I know we do shorter ones now, but yeah, day 4 or 5, they start to feel better. And the other thing is you get kind of diarrhea from the antibiotic, right? It's like, let's stop this. I'm feeling better, and I don't want to have diarrhea. And then this is the amazing one. 50 to 55% of patients on long-term regimens are non-adherent. Now, there are two ways to interpret this figure. I want you to remember this. This could be a mean level. So you can get a bunch of patients, say you have an electronic monitor, you're measuring their adherence to some medication, and you average it. On average, half the people, 50%, on average, the adherence rate among that population will be 50%. The other way you could do that is classify people as being non-adherent using some cutoff point, like that 80% cut point. If you look at that, about 50% of people take less than 80%, or whatever your cut point is, okay? So either way, that's the figure that shows up more often.
Can I ask something?
Yes.
So we are concerned about patients not finishing short-term antibiotic regimens because we're worried about resistance, is that right?
Yeah. The question is, are we concerned about antibiotic regimens not completing them? We're concerned about drug resistance, and you're absolutely right.
And then the other question is, do we have evidence that that's the case, or is it just a postulated kind of makes sense kind of thing?
It is postulated. It's a putative cause of drug resistance. It's been one of the things that's mentioned in addition to having antibiotics in our food source, and the overprescribing of antibiotics by doctors is considered to be. Those are the three factors that I've seen more often. I don't know anybody's done any. Well, there have been a few studies looking at some kids with chronic illnesses like CF that have developed drug resistance to antibiotics, and they've postulated that that's been linked to poor adherence. But I'm not aware of any study that's really monitored adherence in a large group of patients and then see what's the percent of people that evidence drug resistance, and then control other factors and show that adherence is one of the main factors. I think it would be an interesting study to do. That's a very, very interesting question. But that was one of the things I was going to mention here about why should we care about, or why should you care about this as a doctor? Well, if you're unaware of non-adherence, you may order more invasive, risky, and costly procedures and prescribe more potent meds with greater side effects. If your patient is not getting better, that's what you do as a doctor. You ramp up things, right? But, you know, that may not be necessary. If you address the issue of adherence, that may not be necessary to do all those things. The opposite can happen. A physician may believe that non-adherence is why they're having treatment failures. For example, an adolescent, who we know adolescents are more non-adherent than younger children, but you don't adjust their insulin dose when they have a growth spurt. And then they look non-adherent, but in fact, that's your problem. You didn't make that adjustment, okay? So sometimes you have to be careful that you don't over-attribute non-adherence as the reason for treatment failure. Also, in particular, I'm very interested in asthma and juvenile arthritis. We've done a lot of research in those areas on adherence. But there's increased morbidity and mortality related to non-adherence. A lot more kids have functional limitations and school absences if they're non-adherent. They have more ER visits and hospitalizations. How many people have seen asthma patients in the ER? Yeah. How many in the hospital? Almost should never happen. Almost should never happen. We have very effective treatments. We have very clear guidelines on how to treat asthma. National Heart, Lung, and Blood has released those guidelines, as well as a number of organizations. They recently updated them. They're very clear. Even a PhD like me, psychologist, could follow those recommendations and treat a patient with asthma, except I don't have prescription privileges. But they should never, hardly ever, end up in the ER. Occasionally they should. And then fortunately, these asthma deaths have leveled off in, say, the last 10 years or so. It does continue to be the case that African American children die at a rate that's about 5 times higher than Caucasian children. Now, I mentioned earlier to you that African American children are less likely to get inhaled corticosteroids when they need them. So one possible reason for that is that they have inadequate treatment. The other is the environments that they live in. Cockroaches, exposure to triggers for asthma are much greater in the inner city. The air quality is very poor in those areas. So lots of reasons why that may occur. But it is the case that it's much more with minority children. This is really interesting about transplantation. You would think that somebody who gets a transplant would be pretty adherent to immunosuppressive drugs post-transplant. Not always the case. In this particular study, 50% of these 70 adolescents were non-adherent by an assay after renal transplant. 71 of those non-adherent patients experienced rejection, and they had either partial or total loss of the allograft function. This is a dual tragedy in transplantation. It's been repeated in other areas, by the way, in that non-adherence contributes to failures in the recipient, so the people that get the transplant lose it. And then you've got these people on the waiting list dying. So that's the really sad part of it. You've got people, lots of folks waiting for transplants, children, and they don't get it. Our astute medical student here in the front mentioned about drug resistance, and it's good that you guys are really getting educated about that, because that's really a significant problem, particularly in big cities like New York, where TB has emerged again as a really significant public health problem. And if you look at the case fatality rates with multi-drug resistance, it's 40 to 60%, and that's equivalent to the rates that you find among people that are untreated even. So it's a pretty serious problem. The thing we worry about a lot in pediatrics is the children who have compromised immunity, like the kids with HIV, cancer, and CF, who then can develop resistance to antibiotics because they're compromised immunity. And the difficulty then, too, is that there are less antibiotics being developed by drug companies. So if the kids fail a number of ones, they soon may run out of a medication that would work for them. It also increases medical costs in this country. It's estimated that non-adherence is about $100 billion. When we're talking about the trillions and trillions of dollars of bailouts these days, that may not sound like a lot, but it sounds like a lot to me. The cost associated with drug resistance adds about another 100 to 200 million. And this increases the burden on families and society in general. And of course, we're debating all these issues now with health care and reform in health care. It also interferes with clinical trials, non-adherence. The only thing I want to tell you about this as a researcher is that the more you have non-adherence, the more the sample size goes up. You really need a larger sample size to demonstrate a difference between groups. Some people have recommended pre-randomization screening for adherence. So they put people on a placebo drug at the same dosage and frequency as the test drug. If they are less than 80% adherent for the 2-week run-in period, they kick them out of the study. Well, that's pretty good for efficacy studies. That is, does the drug work in ideal conditions? It is not good for effectiveness studies, where you want to know, does the drug work in regular conditions, usual clinical practice. Okay. So what are the risk factors? The 4 females in this room know that males are at risk for all kinds of problems. So that doesn't surprise any of the females in the room. And it turns out that males are more not adherent, and adolescents are, and people are dissatisfied with their care, and people have lack of knowledge, and people have poor adjustment and coping. Big surprise, right? What about family factors? Well, if you got a lot of dysfunction, people arguing, and lots of conflict, not much warmth in the family, all that kind of stuff, non-adherence is pretty prevalent among those families. Lack of parental knowledge, lower socioeconomic status, and lack of parental supervision. Lower SES means a lot of things. It means education level. It means money levels in the family. How much people have to spend. It could be access to care. It could be a lot of reasons why lower SES is a predictor of non-adherence, but it's a very consistent one. Now, I think in pediatrics, a critical one here is lack of parental supervision. And parents often, if you have a kid with a chronic illness, say like diabetes, they will transition the kid into caring for themselves much too early. They pull out of their supervision. Early on, they do a good job of supervising. But they believe that because the kid's 13, there's some magical number, now they're a teenager, they should be able to do all their diabetes-related care. That's not always the case. It varies depending on the cognitive maturity of the kid. So you have to be careful to transition that as the kid can handle that. And you know, the supervision thing really gets into a lot of different problems, not just non-adherence. We recently had, I've forgotten what the anniversary, was it the 20th anniversary of Columbine? The shootings in Columbine? It was on the news recently. Was it 10? Okay, yeah. So, you know, I'm thinking, I have a son who's now almost 26, but when he was younger, the age of those boys that committed that horrific crime, would I have known that he was making bombs in my garage? And the answer to that is yes, I would have known that, right? But those families didn't know. Somebody wasn't monitoring stuff. And we see that in our behavioral pediatrics clinics of people of all socioeconomic levels who don't know what their kid's doing. The Johnson County kids, they have their own cars and they're out doing stuff, and parents don't know where they are. And then you got the inner city kids that are running loose on their own. So it isn't tied to a specific socioeconomic level. But the lack of parental supervision is a very significant factor in kids developing all sorts of problems. In school failure, and acting out problems, drug use, all that, and it turns out non-adherence to medical regimens. Disease factors: if a patient's asymptomatic or in remission, they're not going to take medication very often. It's hard to get people to take inhaled steroids, for example, because it's a prophylactic treatment. You know, it doesn't provide immediate relief of your symptoms. It's much easier to get people to take a bronchodilator because they get quick relief. What about hypertension? Why is non-adherence so prevalent in hypertension? Well, think about it. You really don't have any symptoms, right? Your doctor just says you got to take this because you got to prevent all these problems that can occur because you have high blood pressure. But one of the side effects of antihypertensives is what? Sexual dysfunction. So, you know, sign me up. I don't have any symptoms. I have a good sex life. And you're telling me if I take this medication, I'm going to compromise my sex life. You know, it's amazing to me that half the people are adherent. You know, that seems like a pretty high rate given that scenario. Increased number of symptoms. People probably think your treatment's not working. Younger age of disease onset means you have to cope with it for a long period of time. And if families don't think the disease is severe, we ran into this with asthma, where a lot of family members had asthma, and they didn't look at that as being a very severe disease, when in fact it can be a killer. Complex, demanding, and costly regimens that have delayed beneficial effects, limited provider supervision, and negative regimen side effects are all things that you all can take care of as a doctor. You need to make sure that you can provide a regimen that has the least number of side effects, and if they have side effects, a way to manage those side effects. You need to ask about adherence a lot, and you need to prescribe the least complex regimen that you can. Try to make it simple. Try to make it fit into the family's lifestyle. So how do you improve adherence? We educate people about their disease treatments and the importance of adherence. We organize healthcare in a way that facilitates adherence, and then we use cognitive and behavior change strategies to enhance adherence, which psychologists do, and I'll tell you about that. What do you educate people about? Well, you got to tell them about their disease, the cause, the course, prognosis, treatments, what to do and why you do it. Why? You got to explain why. Negative side effects and how to minimize them. And if you do talk to people about side effects, does it mean they're going to be more non-adherent? No. It means if they experience them and you didn't tell them about it, they're going to stop taking your medication. So you need to tell them about it. And you also need to tell them about the importance of adherence. It's very important that you're very consistent in trying to take your medication. And here are some strategies that you might use, and I'll tell you about those in a second. Educating people with chronic illnesses is an ongoing process that requires effective verbal communication And we used written and other media. We're doing a lot of CD-ROM-based, web-based programs now for children with different chronic illnesses. And then modeling and rehearsing regimens that you're prescribing. So if you prescribe a meter dose inhaler, for example, and you say to your patient, okay, here's the way you do it. You shake it up, you squirt it about this far from your mouth, inhale it, hold it for about a count of 10, and then wait another minute or so before you take your next dose. Did you get that? Okay, that's another are you stupid question. What are they going to say? No, I'm a moron. I missed everything you just showed me, doc. So you have like a placebo inhaler in your office, and you have the patient practice that maneuver. So you know when they leave your office, at least they know how to do it. Now, whether they do it consistently or not, you don't know. But you know that at least they know how to do it. And that's called modeling and behavioral rehearsal. And then organizational strategies, increasing access to health care, going to where patients are. We do a lot of outreach clinics. A lot of the physicians in our department do that. We have telemedicine. We have telehealth clinics now that you can actually have a setup in your office with the camera, and that you can you see your patient and you can do your visits there. And these are being reimbursed by insurance companies. So it's a very good way of reaching people, particularly in our state, in rural areas that have difficulty accessing health care. And then having a consumer-friendly clinical setting. Do we have that here?
No.
No. It's in need of improvement, let's say.
What do you mean by consumer friendly?
What do you want when you go to a doctor's office?
I want a huge parking lot where I can park wherever I want.
You'd like to have parking. Very good.
I don't
And
know.
do you have that here? No. And what else, when you go into your doctor's office, what else would you like?
Free coffee.
Free coffee, be good, sure. Plastic surgeons do that a lot, by the way. I just had plastic surgery, and they're pretty good.
Central air.
Central air would be good, sure.
Perhaps not seeing a med student and a resident.
Yeah, gosh, who wants to see those guys? Get out of here. I don't want to see a med student. By the way, I never see a med student. I don't know how that happens. Maybe it's a faculty clinic I go to. I don't know. I wouldn't care if I saw a med student, but I haven't seen it.
Professional courtesy from your doctor.
I guess. Yeah, maybe that's it. Yeah. Yeah, you'd like to get checked in pretty quickly. You'd like to be put back in a room pretty quickly. You'd like people to be friendly to you, right? You like the doctor to get into the room once you've been in the room. You don't want to be sitting there in your gown with your fanny hanging out, waiting for the doctor to get in there. You like your doctor to be pleasant, to ask you lots of questions, to pay attention to you, to have good eye contact, to really act like they care about you, to know about your history and say, oh, I see that you had your colonoscopy about a year ago or so. I think, Mike, you're due for one next year. That kind of stuff. That's what you want. And I get that from Mark Meyer, who's an excellent physician. He does all those things. That's a consumer-friendly setting. And that's what we should have here. And that we're competing. No longer do people care that we're the academic medical center. People go to Shawnee Mission. They'll go to a different place. They don't have to pay for parking in Shawnee Mission. It's ridiculous that they pay for parking, right? We make it difficult for people to come see us. So that's what I mean by consumer-friendly clinical settings. Then simplifying regimens, minimizing negative side effects. We talked about all of those kind of things. Behavioral strategies, we like to work with parents on increasing their monitoring, prompting adherence. You can use all kinds of devices like the cell phone can go off and beep the kid and tell them to take their medicine. You can have a calendar that they keep track of. You can have those little medication boxes now that, and some of them have alarms on them and they have warnings that you should take your medicine out of there. We work with a lot of parents on incentives. So with younger children in particular, we work with poker chips. They earn poker chips for taking their medicines and they lose them if they don't. And they can trade them in for special privileges, that sort of thing. That works very, very nicely. Discipline, that's a really significant issue with chronically ill kids. How many of you have seen bratty children with cancer? Cancer. Bratty. You've seen any bratty children on the floor with cancer? Or any chronic condition? They're out there. They're out there because parents have difficulty disciplining a child that has a chronic illness because they feel bad. They particularly feel bad if they've got a genetic basis for it. You know, I passed along this CF gene business. And there's good evidence that parents don't discipline like they would a healthy kid. So we have to work with parents on using things like timeout for when kids are little, if they refuse to take their medication. And we tell them, your kiddo needs to be more disciplined than most kids because they have to cope with all the things that go along with having a chronic illness in addition to the regular stuff kids have to cope with. Okay? I don't know what that was, but it sounded bad. It said self-destruct or...
It was a medication reminder.
Was it a medication reminder? Okay, good. So, for example, I'll give you a real practical example. My godson, who I absolutely adore, Caleb, who calls me Dedo. Dedo is the Macedonian word for grandfather. I'm Macedonian, so that's why he calls me Dedo. And he calls my wife Baba, which is the Macedonian word for grandma. And my goddaughter, his mother, Jessica, who lived with us when she was in high school and is my daughter's best friend, she lived with us because she had a really lousy family, and we are more of her family than her real family. And so she calls me one day when Caleb is about 4. He's 6 now. And she said, Dedo, Caleb won't take his antibiotic. And it's flavored and everything, and he was taking it for strep or something. So she would, get it in the syringe and try to cajole him and try to get him to do it, and he wouldn't do it. And so I said, okay, I want you to do exactly what I'm going to tell you, Jess, and this is going to work. Now, we had established timeout with Caleb before that, and I said, what I want you to do is go to Caleb and say, Caleb, it's time to take your medicine. Do you want Mommy to squirt it in, or do you want to squirt it in? No! He immediately goes to timeout. You don't have any further debate about it. He goes immediately to timeout. He's going to be very unhappy and let you know about it. But when he's quiet, you get him up and you say, now are you ready to take your medicine? Do you want Mommy to squirt it in, or do you want to squirt it in? He'll say no again the first time. He'll go back to timeout. Be very unhappy and crying and screaming, all that stuff. And then he's quiet. Then you bring him back and say, now, are you ready to take your medicine? Do you want Mommy to squirt it in? Do you want to squirt it in? He says, you squirt it in, Mommy. Like that. By the 3rd day, Jessica says, Caleb, it's time to take your medicine. He goes, oh, I'll go get it, Mommy. Well, and I want to squirt it in. Oh, that's so good. You're such a big boy. And he had a conversation with Dedo on the telephone. Mommy tells me you've been taking your medicine like a big boy, and you squirt it in sometimes, and sometimes she squirts it in. I'm so proud of you. That's really good. You're going to feel much better for taking your medicine. And Dr. Lauer is going to be so happy with you. Like that, okay? Very simple, but it works beautifully, particularly with younger kids. Now, with older kids, we have to get into things that are a little more involved, like self-monitoring, problem-solving, those kind of things. This is Lindsay Rapoff in timeout, just to remind you what it looks like to be in timeout. That is a posed shot, by the way. She ended up in timeout sometimes. That was actually the timeout place in our old house. Now, the other thing, I don't like the way this is not fitting on the screen. It usually does. But the other thing we ask people about, let me just tell you briefly, teenagers, is what their thoughts are about their medication. Because the idea being that how you think about things influences how you behave, right? So this young lady here had lupus, and she was taking prednisone every other day, and she was very inconsistent. We had data on this. And I asked her about it. She said, I take my medicine depending on how I feel, sometimes more, sometimes less. It's exactly what she was doing. And I said to her in a non-judgmental way, okay, if you follow that line of thinking, what are the possible positive or negative consequences of thinking that way? Well, if you're on a PRN regimen, that's okay. You can take it as you feel. That's what it means, right? But you're not. You're on a regimen that requires it to be continuous and consistent. And you are not going to get better. You're not going to control your symptoms with that. So the idea is to try to get an idea of what the teenager's thinking about and how that's influencing their behavior and changing that. The other thing that we've looked at is barriers to adherence, and we're developing questionnaires for parents and kids about what gets in the way of you taking your medication. Like, I don't take my medicine because I feel fine or don't need it. I don't think my medicine is helping me. And then designing interventions based specifically on the barriers identified by the family. Now, we're doing these web-based and CD-ROM-based now, and the neat thing about that is that you can do this barriers questionnaire as part of your intervention. And if they identify certain barriers, the program branches off into a solution for that specific barrier. So we're going to tailor that intervention to the specific barriers that families have identified. We've not yet found if that's effective or not. We're just beginning to develop these programs and test them. But I'm very hopeful this is going to be be helpful. So here's the take-home points for you all. Less than optimal treatment outcomes, consider adherence. Ask patients and their families about adherence issues. Negotiate a willingness to try a particular regimen and explain the importance. Make sure patients and families have the knowledge and skills to carry out the regimens. Simplify the regimens and reduce side effects. And this Rapoff guy wrote this book. It's the second edition is coming out this year. I know all of you will want to get a copy for family and friends. It's always good to give around the holidays, Anyway, not many people buy this book. It's like my graduate students have to buy it. I always make them buy it. But it's the only single-authored book on the topic of pediatric medical adherence. And now it's twice the size. I redid it when I was on sabbatical last year, so it's out there. Questions? Got about 2 or 3 minutes. You ask a lot of really good ones during the talk, so. Questions? Thank you for your attention. You guys did a good job of. Do we need to turn that off? Don't move, though. The pediatrics